Good afternoon again. This is Dr. Bill White, and I'm going to show you some pictures of a skull here that is very accurate and helps a lot. So I think we should know more about it. And I'm going to try to get this up. Just bear with me a minute. All right, this is a skull that I purchased probably 60 years ago when I first started. It has been worked over, and it shows the blood vessels, it shows the cortical bone and the other aspects of the skull. Let me back away from it just a little bit here, and we'll try to get out the details in it. Now, one thing we work with a lot is the temporal mandibular joint that you can see right here. And you see the way the joint fits up into the socket where the teeth are fitting together back over here. And we've got space where the disc functions in there, but the space up behind the temporal mandibular in the temporal mandibular joint, the condyle, fits up. There's an area up there at the top and kind of to the back where the retrodiscal tissue lies, and that's where your blood vessels and everything are made back in this area right here. And that it's just a miracle how that works. This synovial fluid, which is very slick, it's so smooth, we can't make an oil as good as that, commercially anyway. And this has not only just the lubricant for the joint, but it also has food structure in the joint. And it feeds the disc that fits right in between the head of the condyle and the fossa right here, where the fossa comes around in that area. The disc fits right in there. Now, when you bite with your front teeth, you move your jaw forward. And when I move this jaw forward in here, the side teeth back here come out of contact. In other words, the condyle goes up. The condyle will go up on the eminence like that, something like that. And now the teeth in between don't touch. That's the way it should be. And if you look at your own teeth, when you bite forward, your condyle will move forward, and then the posterior teeth back in here won't actually come in contact. And so now, when I bite down with a force right out here on the front teeth, there's nothing touches in this area right here. The pressure is back here on the joint and on the front teeth right up here. And this puts a tremendous pressure on the disc, the tissue underneath there that's taking this pressure, and the muscle, the masseter muscle and the temporal mandibular joint, the muscles are attached down here, also attached up on this coronoid process, and they're attached to the skull up here. And these are one set of muscles. They don't have to fuss at people to use. I mean, we chew all the time, and these muscles are very stout, and they can put a tremendous amount of pressure out here at the anterior part, and that you can feel it in the teeth, but you don't feel it back here. But there's more pressure here because the where the muscles that of mastication come down through the body here. Let me get over here where you can see a little better. And I'm going to turn it back, and you can see the size of the muscles. They go down about where that spring is, right in this area here. They go down through there and they're attached right up here. And they put a tremendous amount of force, but the force is back in this area, and it's much closer to from the muscles to the joint than it is from the muscles to the teeth out here. So if you put 10 pounds of force out on the anterior part of the mouth, you may have 20, 25, or 30 or more. I don't know exactly what it is, but it'll be a lot more than it is there. And so that's why the disc is a little round donut shape. It's not exactly round either, but because you see the head of the condyle. Let me get it here where you can pull this condyle down, and you see that it's a kind of an oblong area, and it's made so that you can chew from side to side. In other words, if you chew one way or the other, this will move, and you can chew on the left side or the right side, and now you come back and you chew on the left side. And this condyle shifts positions in here as you chew from one side to the other, or if you bite forward, then the posterior teeth don't even touch back in that area. It's a complicated thing. Now, another thing we should understand about the skull, and one of them is the sinuses. These are the frontal sinuses right here. If I pick this up, the whole thing will come apart, but you can see this inside this. Let me get this over here where you're looking at it. You can see the sinus there. Right, that's the frontal sinus, and this latches that up. And here's the outer surface of it. Now this sinus drains into the nasal cavity. Now I'm holding it at this angle right here, and you can see the turbinates. And this is the third turbinate is small and not too much, but the turbinates are up in this area. If we look at them from the front, and that's the nasal septum that's been cut in two right here. You can see where the nasal septum is, and it wiggles around. You can see if I take this apart, you can really see that good. Now I'm going to try to look at these turbinates from the inside to the outside and kind of get you some idea about what they're like. Now, from the inside of the mouth, the turbinates, I don't have a good view from this part right there, and I'm going to separate the skull, and that'll give me a little better view. Now, this skull's made where you can take it apart and look at the different portions. I'm going to disconnect this spring over here, and that'll kind of let me show it better. Now, these are the turbinates. You can see the nasal septum right here. This is the septum. Underneath the nasal septum, there are three turbinates. The lower one is by far the biggest one, right here, and this is covered with tissue and cilia that pick up dust and grit and stuff that we swallow. This is where fluid drains into it, maybe from the sinuses or the frontal sinus. And then you have your middle turbinate, and this is the upper turbinate, which is very small and right close to the tissue there. Now, I was studying the temporal, the device for separating the attachment where the tissue joins the right and the left side of the mouth together. We put a device in here, and it works from the molars and the bicuspids, and it pushes back here. But by far the most bone structure that we have to separate is the bone structure between the two central teeth, right in this area, not this tissue, the roof of the mouth, and our pressure is back here. So this is like trying to separate something out in front of you with your arms. You can't do it very good, so you pull it up close to your body and put the same pressure on the thing, and you're able to push this apart. Well, I talked to the guy named Donald Timms, wrote this book on the palatal separation. And this is one of the best things you could do in doing orthodontics for a kid that's a mouth breather or something of that nature. So I wasn't getting people separated early or further in life. I mean, people that are 30 and 40 years old need to have their palate separated. Their teeth will be biting and cross-bite. Their upper teeth are more narrow. The bottom jaw, if you're breathing through the mouth, you put your tongue on the bottom and nothing up on top to hold that. And so the upper doesn't develop like it should. And these are people that really need the sutures pushed apart and the whole palate separated and broadened out, at least where the lower molars are, and you can let them come in a little bit. But this causes crowding, and then that affects the airway. Now this, you turn this up where you can see down into this portion right above. In other words, where the turbinates are, that this is your airway right in through here. And this does not develop properly if your teeth are too far in toward the center of the mouth. And get back where you can see that again. So it does develop in that place where it is. But we can put a palatal separator in on somebody, and I've figured out that if you put pressure between the two centrals right here, you're pushing apart right at the place where the most bone is. We were able to separate people, some of them even 40-year-old people, we could separate the palate from them. Now some of them I can't separate, but I've shown you one man that we had he weighed 312 pounds, and we were able to spread his upper jaw out. He didn't mind the pressure, and we just spread it out. He was in crossbite up above, so we can expand even older people's mouths. We can do it slowly with a big daddy arch wire, or we can put a palatal separator in. It's better in cases like that to do the big daddy wire, and it'll just expand anybody's mouth and get it out. You have to put the buccal root torque in there to torque these roots out. You need to bring these roots out when you spread it out. If you don't, they'll be leaned in like this, and that still doesn't give you the airway that you need. I realize it's hard for me to show this to you exactly. This is the nasal septum. Now sometimes this nasal septum will be deflected or bent. You get football, you get hit in the mouth, you break your nose, it bends the nasal septum, you box or you just have an accident and it bends that thing, and it'll be touching one side. It kind of blocks the airway on one side of the mouth and blocks it also on the other. So these are just a few of the things that you're going to run into, and you need to have some understanding of this. Now, this sinus, frontal sinus right here, I'm going to try to open this little door to it, and it's been chipped or broken off. But there's how big the frontal sinus is. Can you see that? The sinus closes in like that. Now, one of mine was stopped up with thick junk that wouldn't drain out, so they had to go in and open it. And they went in through the nose and opened the sinus up into the upper part here to get where they could flush this out. And some people get infected sinus. My father had that too. Maybe there's some relationship that may be genetically rigged up there. But anyway, my father had a sinus that was just completely blocked, and I did too. So that's something that affects the teeth. Normally the teeth get sore because the roots of the teeth are sticking. If we look at this, if I can get over here and show it to you, the roots of the teeth are just tissue, a little bit of bone structure between the sinus and the tooth root right here. And the sinus is just an empty space normally, but you try to keep it drained and flushed out good. And if the sinus gets to hurting or gets inflamed, the teeth will hurt. And people will come to you and say, well, I need to have a tooth out. It's just really hurting. And it won't be anything but the sinus is being infected by some material that stays in the sinus, and gets it inflamed, and that makes the teeth have their roots right up in the sinus, will feel that. So there's all kind of things that it's good if you understand the bone structure around the teeth. Now, for instance, if you want to put a little screw in here, or a tad as they call it, you want to go through this cortical bone, this hard bone. So you drill a little hole that's smaller than the screw that you're going to screw in, and it holds on the cortical bone. But the bone structure inside the cancellous bone, let me show you on this other half of this, it has a little better view of the cancellous bone. Let me take the jaw back. Well, I'll just use the lower jaw for it. Here is the teeth where they remove the cancellous bone. But can you visualize, and get that in good focus, where you can see the space between the cancellous bone? Now the cortical bone is very hard and very tough. The cancellous bone is not. But it doesn't hold a screw good either. So you want to get your tads into cortical bone if possible. and it's best to drill a little hole slightly smaller than the screw or the tab that you're going to put in there, and then you can bond that to the tooth up there, and that won't move hardly any at all. If you move the whole jawbone out, expanding it or something, it'll go with that, but it doesn't move on its own. Now somebody dropped this thing and busted my teeth up on this the side right here, but it still will show you where whoever worked on this thing really did a lot of work. I mean, they cut that with a fine saw and then took the nerves out, you see. Now there's cancellous bone. You can just see it's all over the place here. And the teeth are down in the cancellous bone, and that's where the nerves and the blood vessels and the lymph vessels, and you've got an artery, you've got a vein, and you've got a lymph vessel in there in that same tooth. It comes in the tip of the tooth, supplies the nerve structure in that tooth. And when they do, you have one that gets the nerves is dead, you have to go in and do a root canal. They have to clean it out and get it cleaned all the way to the bottom where bacteria can't live in there and your body can't get to it. And so the tooth abscesses, if you can get this down and clean it completely to the tip of it, then the blood vessels can take care of the infected area much better. So just, you could sit here and talk all night about what goes on in the mouth right here. The lower teeth, and by the way, this looks rigid and hard, but this is movable, and it moves all the time. And you can actually expand it on older people. If you pull these teeth out, the bone structure, the alveolar bone that holds the teeth moves, and the basal bone underneath here, it moves also to widen. So people who breathe through the mouth constantly will develop a wider mandible, and it'll bite cusp to cusp, and you bite your cheek, and I know that's a fact because I'm a mouth breather, and that has happened to me. So I don't have to have a double-blind study to tell me that that's what's going on in there. A little bit ago I was talking about the condyles. You'd think of them as a kind of a ball up there with their oblong structure right here, and you can see the distance from here to there. Now that the jaw, you chew from one side to the other. Like I can bite my left side together, and my right side doesn't touch at all, simply because if I were here and I'd bite my left side together, I'd bite this together, I can shift my jaw over this way to bite together, they hit on the cusp, and then that disarticulates the ones on the right side of the mouth, and they don't touch anything. Your anterior teeth will touch up here together. So it would be good, my thinking, rather than destroying or throwing away all the natural skulls that they have been, people give their bodies to science, we should be able to take them and work that over and let somebody have it to study what happens in the mouth. This is I've just given you a little portion of what is known and what can be done with this. And so I'm going to say goodbye, and we'll try to add that. Excuse me just a minute. My vocal cords kind of get stopped up there. But I'm going to go ahead and finish this out, and we'll stop it. Thank you for watching, and I hope you will join our group and subscribe to it. And I hope that we can pass this on to people around the world that can't get two skulls like this to study them. Thank you now for watching, and I'm going to hang up.